Okay, good morning, everybody. Welcome to the updated carotid referral pathway. With our lovely presenter today will be Dr. Nicolas Greaves. My name is Farheen Akhtar, and I am one of the facilitators with the network. And just a little bit of housekeeping just before we start. Please keep yourself on mute and your cameras turned off until you have any questions. And if you would like to pose any questions, then please do so virtually, just by indicating via raising your hand, and we'll address you and ask you to pose your question to the panel. We are recording this event today, and a recording will be emailed afterwards via Lisa. We do ask at the end if you would provide feedback of the session, and then our Twitter handle is GMNISDN. We do ask that you tweet us as well. I will put a little link of the future events, a link for the training for future events on our website in the little chat as we get started. And if there's any further details that you do require, please do email Lisa and she will get back to you. Thank you.
Okay, morning everyone. My name is Nick Greaves. I'm one of the consultant vascular surgeons based at the MRI, obviously part of MFT, and I'm the MFT carotid lead for our service. And in my experience, this is the first time I've had any contact with the stroke network, and we do sort of work a little bit as two separate entities. That you refer to us, we operate sometimes, and then they go back to you. And it's the first time we've had any kind of interaction. And given our service is expanding enormously, we wanted to update and streamline the carotid endarterectomy referral pathway because it has been a bit clunky in the past, a bit hit and miss, and it needed tidying up. So today is just to sort of outline the very simple changes that we've made to discuss the service that we have, and then for you to flag up any questions you might have about how it is from your side, because I can only really comment on what I see from my side. So I just wanted to go over briefly to start with just how the vascular service is divided, or has been divided in the past. And previously in Greater Manchester, there were three main vascular hubs: Wythenshawe or UHSM, the MRI, and Oldham. And then in 2017, the MRI was delegated as the major vascular hub for Greater Manchester, with subsequent mergers from the other trusts. So although Wythenshawe and the MRI became MFT in 2017, the vascular service didn't merge the two units until October 2020. North Manchester also became part of MFT in 2021, although confusingly the vascular service, or the vascular patients at North, are still referred to Oldham and Pennine or Northern Care Alliance. And then at some point, either April or August next year of 2023, the Oldham vascular service will merge with us, so that all the vascular patients in Greater Manchester will only receive arterial surgery at the MRI. Obviously, we'll still have spoke sites, but all the service will be based at the MRI, where all patients have their operations. And obviously, Greater Manchester being a big place, that's a lot of patients to try and fit through one hub. And therefore, the hub-spoke model is really important. There's movement through the system for us to keep functioning as we do. So I just wanted to give some sort of feel for what kind of numbers we're doing. The NVR is the National Vascular Registry. It produces a report every year on every single trust, NHS trust, that's providing a vascular service and how they're performing in comparison to the others. So this graph basically shows on the x-axis the number of operations performed. This is actually over a 3-year period, and then on this y-axis is the percentage death and stroke rate. We're all aiming for the green line, which is the national rate we're targeting. And what you can see is that MFT is actually the second highest provider of carotid endarterectomy in the entire UK, obviously with quite good outcomes. And then when you combine that with Pennine at 8th. So when you merge Pennine and MFT, you're going to have a service that is at least 1.5 times bigger than the next biggest service. So it's big numbers and high throughput through our units. Fortunately, this slide shows that whichever methods we've used in the past seem to have worked effectively, because this is the median delay from symptom to surgery. And actually both us, which is ROA, and Pennine, which is RW6, are well below the 14-day target. for that at the moment. Although we found increasingly over the last year, we are struggling. The hospital's a lot busier. It's harder to get beds. So we are concerned that we may start creeping towards that red line if we're not careful. So I think most importantly to stress is that the referrals we want to receive, the criteria for someone having a carotid endarterectomy have not changed. That doesn't change. It still remains. And what we want is a symptomatic carotid territory infarct or TIA within the preceding 6 months, but ideally as soon as possible, for anybody with a greater than 50% nascent stenosis of the relevant carotid territory. That's the bread and butter. Obviously, more importantly and more urgently, the crescendo TIAs and the stroke and evolution. We get a lot of referrals, which are all very good. However, having been a registrar here in the past, we do receive a number of inappropriate referrals. And more importantly, what we want to stress is what we don't want. We don't want anything that has a less than 50% stenosis on CT or duplex. We don't want anyone who's got an occlusion of the relevant carotid artery. We don't want anything with a string sign. String sign is a diffusely narrowed internal carotid artery, and there is no evidence just that any of those three groups actually benefit from carotid endarterectomy, and they are effectively wasted referrals. But furthermore, it's important to recognise we don't want people who are a ranking score of more than 3, have significant levels of altered consciousness, or huge infarcts or signs of hemorrhage on their CT scan. So that's nothing new. That's just to reinforce what we want. And if it can filter down to the juniors, that would be ideal. Because as I say, we do see a huge range in variability and quality of referral, depending on what level from F2, anything up to consultant, actually makes the referral to our service. So what happened in the past was that whichever spoke service or stroke service wanted to refer a patient to us, they had to get on the phone, bleep the vascular registrar at the MRI or Wythenshawe, and actually have a chat with them, which was not overly satisfactory for you, I suspect, because you waited a long time because they're busy. And for us, it was a bit of a logistical nightmare because it really depended on the quality of the registrars, how well they documented, and how good they were organising things afterwards. So the next driver for it was that since we've merged, our vascular registrar on call is just one person for 24 hours. They're absolutely swamped and inundated with activity, and it's incredibly difficult for them to keep on top of everything, given they're covering theatres, admissions and the wards for 24 hours. It wasn't safe, it wasn't effective. And so we decided to switch to an email-based service. I created this standardized pro form, which I'll show you in a second, so that can be filled out remotely, emailed to us, and then we act upon it. And the difference is that goes to a consultant. So every day here we have a consultant for the wards and a consultant for theatre. The consultant for theatre has a bit more time on their hands, and they can then go through this email box to see all the different referrals that have come to us, and they can act upon it. That then gives us a paper trail, which is better for audit and medical legal purposes, and it can be accessed 24/7, as opposed to the registrar's bleep, which goes off non-stop and is a bit hit and miss. So this is the referral pathway that we've changed to. It's a PDF file that's been designed for ease of use. And although it looks like fixed boxes, all of these boxes can be expanded to take in as much detail as you want to put on. It's pretty straightforward. The first top left box refers to all the patient details, who they are, where they are, their identification numbers, who they're under and which hospital they're coming from. The next box is their symptoms, most importantly when their last symptoms were, what the symptoms were they thrombolized. Then some background for us on how fit they are for any kind of surgery, their relevant risk factors and other significant information. We obviously commented that we don't want people with modified ranking scores of over 3, and that goes in here. And then for us, the most important part is the quality of the imaging and how much imaging we get. So there's a variety of different modalities, of which just dates and a bit of information will be very useful to be filled out, so we can make an assessment whether this person needs surgery or not. Also, it affects us whether they're on anticoagulants or antiplatelets pre-event and what they're on post-event. And then finally, in terms of discharging patients, where are they going to? The vast majority go from us back to their home, but some do need to come back to the referring centre for further rehab. And actually, it's vital for us that anybody who's in that category does have a bed sort of ring fence, so they can go back as quickly as possible once they've had their surgery, because we have such high throughput for us. And then finally, the referrer details, who's referring to us, how we get hold of them, what's the best contact email address. And that is an area of discussion which I'll bring up later on. Obviously, because your junior doctors will do a day on call where they're referring patients, they're not on call. Is there a generic email box that it needs to go to? What's the best way to get back to you, essentially? Once that pro forma is filled out, it's simply emailed to that email address, carotid.referrals@mft.nhs.uk. And so that goes into a dedicated carotid referrals inbox in our Outlook that the surgeon of the week then looks at each day for the 7 days that they are surgeon of the week, and then acts upon in the following manner. And basically there are 4 fairly straightforward outcomes based on what they've seen. They can either request further information about how the patient presented or anything that's missing from the information on the pro forma, or whether they want further imaging. Most commonly, we will organise a hot clinic. That's a vascular hot clinic, usually at the MRI, but sometimes at our spoke sites, to actually physically see these patients. I think that's the most important step for us, is actually seeing them face to face, so we can discuss surgery with them and see if they are good, surgical candidates. A small percentage will be discharged because they're not appropriate. Those with occluded carotids or percentages less than 50%. And a very small number will be accepted directly for carotid endarterectomy. This will not occur from now on until the patient has physically been seen by us, whether it's here or at the spoke. We've had enough incidents where we've been stung by accepting people who come across who are just not appropriate for surgery. Then they're sat in a bed for days and it's just not right. So they're the 4 commonest outcomes, and all those outcomes will be communicated back to the referrer by email. And then once they've received it, they can act upon it. And again, it's an email dialogue from one to the other, which should make things much more streamlined and not have to go through switchboards and waiting for bleeps and all that sort of thing. So one other issue that is commonly flagged up as being of concern for spoke or stroke centres referring to us is what imaging to get for these patients and when. And the vast majority will have a duplex, but as part of our kind of optimised service, we want 2 forms of correlating diagnostic imaging prior to their endarterectomy. And it used to be in the old days that 2 carotids on 2 different days, 2 duplex on 2 different days by different people was enough. And that may still be the case, particularly for the slightly older consultants. However, the newer bunch are much more keen on duplex and CT. And CT highlights a number of issues that we probably weren't aware of in the past. It identifies tandem lesions, high bifurcations, skull base intracranial disease that affects our decision, as well as intrathoracic common carotid disease, but also identifies other important adjacent pathology, such as a newly diagnosed lung cancer or something else that would immediately tell us we probably shouldn't be operating on these people. So the vast majority will receive a duplex as part of your one-stop clinics or TIA clinics. And most of us would like CTs for most of the patients if they're going to be an endarterectomy candidate. However, I think it's important to stress that we don't want to overload your radiology departments. We do find it useful to get them done at the spoke rather than here, because we have enough capacity at the MRI to fit all these patients in, but we do not require the spoke site to formally report the CTs. We are perfectly capable of interpreting the CTs by ourselves. If we have difficulty, we have our vascular radiology colleagues, we have an MDT to go through imaging. We will make the decisions based on the imaging you can get. And the faster you can get it to us, the quicker we can make any decisions on whether the patient needs surgery or not. So obviously they will have to be formally reported as part of the audit process at your spoke, but there's no time pressure. And as soon as you've had this imaging done, again, an email to that email address to let us know it's done and we can make a decision. So we sat down as the 12 consultants who are based at MFT, and we had a chat about which patients are absolutely obligated to get a CT before we consider surgery. And we came up with 9 different criteria that we think all should get CTs as well as a duplex or an MRA. The first is borderline 50-59% stenoses. The second is greater than 90% stenoses. Anything where the duplex suggests proximal or distal tandem lesions. Anything where the duplex is obscured by calcification or doesn't give enough accuracy definitely requires a CT, and that's not uncommon. Anything where there's a suggestion of high bifurcation on the duplex. Any patients with a high BMI or short thick necks, which makes surgery much more technically challenging and higher risk. If the carotid plaque is very long, for me personally about 2.5 centimeters, but some of my colleagues wanted more than 2 centimeters. If the patients have previous radiotherapy or surgery to the neck, anything that's going to make the surgery much more technically challenging. And then finally, our get out clause, anything where the vascular surgeon uses their discretion or has concerns about the duplex's validity. So we will obviously get back to you if we want a CT scan for these patients, but the first 8 are an absolute. Anybody with any of those criteria must have a CT as well as a duplex before it comes to us. So I hope that clarifies that. Obviously, carotid stenting is also a service that we provide. It's very niche. It doesn't go for that many patients, and there are very specific criteria, but anybody who is a candidate should come through exactly the same referral process to us, and we will liaise with our interventional radiology colleagues to discuss it, put it through MDT, and get them listed for a carotid stent at Wythenshawe. Currently, we're only doing about 10 to 20 carotid stents a year, for good reason, because they are higher risk in some respects, but equally for the right patient, they're very good. So that was a very, very quick run through of everything that I wanted to bring. The most important thing is the carotid proforma and awareness of it, and that it should be referred to us. We shouldn't be phoning the on-call registrar at the MRI anymore. It should go through the proforma, and we will get back to you usually the same day or the following day with outcomes for those patients. So I just wanted to open the floor. Obviously, I only see it from my perspective. You guys see it from the stroke perspective, and answer any questions that you may have, and talk about anything that you need to, any ideas that you want to talk about, any way to optimize it. And then there are just a few points that I thought we could talk about if there weren't any other questions of issues that had been flagged previously. So feel free to open the floor, and I'll answer any questions you've got.
Thank you so much, Dr. Greaves. We have 2 hands up. Is it Dr. I can't say your name. Nayaran Rudy, do you want to put your question, please?
Hi,
Sorry.
I'm Dr. Saronan. Okay, thanks. Yeah. Hi, Nick. Just one thing. I think, when is it starting? I'm one of the stroke physicians at Fairfield Hospital. Is
Okay, right.
Because
so this is the most important distinguishing feature. So Oldham is still its own vascular service until at least April, August next year. So at Fairfield, you'll be referring to Oldham. Nothing changes for your referral process. You still do whatever method they choose to use. Okay. This is just for anybody who will be coming to the MRI, which is, you know, stroke, Salford, Bolton, etc., etc. So for you guys, it won't change. For MFT, this proforma has been in place for about 4 weeks now. Certainly from our side, our juniors love it because they're getting less phone calls. The consultants have ownership of it, and we think it works much better pinging emails backwards and forwards because it's much quicker and effective.
Okay, thanks.
Thank you for your question. Dr. Siri Purapu, would you like to put your question?
Thank you. You got my name right.
Thank you.
Hi, Nick. So I am Rekha Siripurapu. So I'm a neuroradiologist from Salford and the lead for stroke imaging the last 10 years. Thank you for that presentation. So that was, very clear. I have a couple of questions. I mean, having seen, the vascular surgery transform in the last 10 years, and I think you said, there are variations in practice. The imaging part of it, has any neuroradiologist been involved in drafting up these criteria at all?
No, not yet. I mean, we have, I say, the 12 vascular consultants all sat down and we had a discussion about what we felt was important in terms of imaging prior to us doing the operating and inheriting the patients. We've run it past our vascular radiologists, but no neuroradiologists per se.
But your vascular radiologists don't report carotids, do they?
Our vascular radiologists do report carotids, yeah, absolutely.
Okay, and they report CTA and MRA of carotids as well?
Yeah, so anybody at the MRI will report that, absolutely. Okay. Obviously, the vast majority of our referrals come from elsewhere, so they don't tend to get reported by our consultants unless we take it to MDT or something else, but they're very happy to interpret it, as are we.
Okay, thank you. With regards to the criteria, I can see, your 9-point wish list. I mean, yeah. That's that's brilliant. But I can come back to this after, I mean, I can see, sure. Dr. Sain, he's a stroke lead. He's put his hand up as well. I can come back to this, or I can go through now. I don't know how you are for time.
I'm fine for time. It depends on everyone else, but I'm happy to discuss it.
Go through it. I think I was going to say that I wanted to bring you first in terms of discuss the imaging modalities, where my questions are mainly kind of service related and a few problems that we're having, which I understand, Nick, it's not a criticism. It's just like a new service. It will have a certain things, and we just have to be accommodating from either side to iron it out. I think the more important thing is to agree an imaging protocol, so we know what we are requesting, what's the time frames of reporting and getting it back to you. So I'll let Rekha maybe speak with you and get a feel for it, and then I'll come in. Mine's are mainly logistics.
Sure.
Thank you. So you see, from our point, I completely agree with you that there are cases where dual modality is necessary. Point taken on that. But in choosing CTA versus MRA, so capacity, I'll start from the capacity issues and then the clinical side of things. In terms of capacity issue, I mean, we are at really beyond capacity at Salford, because we have not just the carotids from the stroke side of things, but we have all the vascular imaging from neurosurgery, trauma, I mean, pretty much everything. In terms of, so I think capacity, we will have big issues, both in terms of doing as well as reporting them. Now, on the clinical side of things, yes, I think CTA is really good when we're looking at a near occlusion kind of a picture, which I know you will not operate. And I keep telling our trainees the same thing as well. If it's a near occlusion, that's it. But the more than 90%, I don't know how that number came in.
It's more that a small percentage of these carotids will occlude between initial imaging on duplex and then coming to us. So we'd always want the second form of imaging to confirm that yes, it is patent, it's not a string sign, and that there is an indication to operate.
Okay, so then should that not be done at your local centre before the surgery?
So this is obviously the bit I haven't talked about is that what we do here. So we do have at least one. We've got one trying to get 2 CT slots per hot clinic here to fill in the blanks with imaging that we can't get elsewhere, or there's too much time pressure or whatever else. But obviously we have 10 patients per hot clinic. If you're getting 6 carotids like there are on this morning, we can't get 6 CTAs done at a time. So we're trying to encourage the spokes through as much as they can, appreciating that you guys are swamped as much as we are. And between the two of us, we should get the imaging that we want before we operate. And frankly, we're not going to operate until we've got the imaging. So we have to wait. We'll wait and get it done here. But it's just to encourage you, if you can, please try. Not expecting you to do everything, because we appreciate it's too much.
No.
And actually, what we've seen from the referrals so far is that actually most patients are getting CTAs now. That's not through us pushing. That's just a gradual evolution of the process from what we've seen. We're delighted, obviously.
That's what you're seeing from your side. You see, from our side, we keep saying, no, vascular surgery won't CTA on this. They absolutely won't discuss if we don't have CTA on this. So it's a different thing. In terms of calcification, you see, I take your point. If there's heavy calcification on duplex, it is hard. But you see, in these, MRA is certainly a lot better than CTA, because CTA is really going to, pardon my use of the term, mess up the estimation. And to be honest, if there's heavy calcification, if it were me, I'd rather have an MRA, because we also do a plug sequence. And if there is intraplug hemorrhage and calcification, it's an important thing. So that's.
I think we're not averse to MRA. I mean, my familiarity in interpreting MRI is much less than CT, but certainly cross-sectional imaging of any variety is acceptable. That's why it's on that list. And certainly nice guidance is MRA. So we would accept MRA. I just wouldn't be able to give you as quick a bit of feedback on it if I was just sat looking at it now compared to CT.
Oh, to be honest, we report all our inpatients pretty much the same day.
Yeah, so, well, I mean, if you do, that's great. But as I say, there is a spectrum of speed of reporting across the region. Some are very quick, some aren't. And that previously has been a bit of a rate limiting step for some centres, because they thought they couldn't discuss it with us until it's been formally reported. As soon as the CTA is done, we can access it via sector, we can see it, we can interpret it, that's fine. MRA less so. But, if you've got a report, then that's absolutely fine.
Okay. Because I think from the MRA perspectives of our side, both looking at the European guidelines that have come out as well, they kind of give an equipoise between MRA and CTA, don't they? I mean, and to be honest, Doppler in great hands like your centre, Vascular Lab, is as good, to be honest, and it's been validated as well.
Yeah.
Okay, so you are happy for us, you know, you don't insist it has to be a CTA, because that's one of the big things.
No.
Okay.
Cross-sectional, I mean, I think that's important as well as a Doppler, but it doesn't have to be CT.
Okay. Yeah, I think that's pretty much it. There is a kind of a modified thing that we had looked at. And, you know, I think, I don't know, but I think Dr. Choi is logged in as well. So he's the CD for neuroradiology. Would you just want me to share that, Cameron, just to see what Nick thinks about that? And obviously, I think this is the first step. You know, we would like to have couple of conversations at least to take this forward, because I am as much a believer in carotid and plaque imaging. You know, I've been trying to get this going for the last 7 years nearly. So, you know, I think we want to do the best for the patient, but I think taking into consideration the capacity issues, both for reporting.
Sure. Go ahead, Drake. Yeah, I think if we can use MRA a little bit more at Salford, that would certainly help with capacity, because you know, once you're experienced at doing that, it is a little bit faster to report an MRA.
So let me just do let me know when you can see my screen share, please. I'm not at the slide that I want to show, but I will move through. Are you able to see the screen share?
Yeah.
Okay, so I'll just skip all that. That was nothing. So this was a couple of things that we were having issues with. One is increasing requests for CTA, and Nick, we had audited this last year. So Doppler suggesting second modality due to body habitus of calcification absolutely indicated. We completely agree with that. So this is the thing which I couldn't understand, and I think this is where we wanted to have a chat with you. Second modality, despite a good ultrasound report, including less than 50% in occlusion. So these are the two where if the Doppler is categorical, we don't need a second modality.
No, I agree with that.
Okay, because these are the things that we had requests in, and we were, you know, kind of blocking and saying, no, I think the Doppler is unequivocal. You do not need a second modality for this. So the next thing is the imaging to be performed same day whilst in hospital. So I think capacity issues with this, because what we had seen, you know, in the audit and looking at the patients is, but then you've clarified it as well, that these patients are seen in a hot clinic later on, and endarterectomy at some point within the 2 weeks.
Yeah.
So from that perspective, you see the pressures that we have is literally we get asked to do the CTA the same day or the MRA the same day, which is difficult. But if things can be arranged in terms of having outpatient or, you know, like virtual clinic appointments, I think that'll make things streamlined a little bit more. And I think Dr. Sain might speak to you. So this is our ideal wish list. It's shorter than your 9-point wish list. But see what you think. As I said, it's all up for discussion. So less than 50%, we both agree. We don't need anything. So we're happy with that. So if ultrasound suggests a second modality due to a difficult scan, be it high bifurcation or calcification, personally, we would prefer MR brain and MRA. Again, first is you will pick up the infarcts. You will pick up if there are multi-territory infarcts. We will pick up plaque. We routinely do plaque sequencing now here, so it's part of our imaging. So that's our go-to modality. Now, this is the bit where I wasn't sure. If it's near occlusion and occlusion, I certainly think we don't need a second modality, and I'm really glad that you agree the same. But it's the 50 to 79 stenosis with no technical issue. I don't know how many proportional these are, but
so yeah, no, we found that CT tends to underestimate the stenosis compared to duplex. So 50-59 on a duplex tends to work out as less than 50 on the CT, and that's why there's some discrepancy. Anything that is, you know, barn door symptoms with a barn door 60, 70, 80% stenosis, I don't think it needs a second form of imaging. I think most of us would be happy to go ahead and organise it and get on with it. If that particular surgeon wasn't, they would then have to organise a second duplex or CT off their own back. But anything over 90, again, we just need to make sure that A, it's still patent and there's nothing else that we've missed.
Okay.
So I personally think that over 90 and less than 60 needs a second form of imaging, ideally CT or MR.
Okay.
But in between, with a barn door story, I don't think it needs anything else.
Brilliant. Okay, thank you. So we could probably tweak them a little bit. I mean, I know it's site specific, so I will not. I mean, I cannot talk on behalf of other sites. I think what I'm speaking is purely on behalf of Salford Royal.
No, I understand. And I think just the caveat to your second point, I would accept MR quite happily as long as it's reported. And if
Yeah.
you say you're doing it same day, then there's no delay.
I mean, pretty much same day, next day
Yeah.
morning, you see. So we
Yeah,
don't,
no,
you know, our end patients don't
sounds-
wait longer than 24 hours.
That sounds excellent. It's just that I know from experience, other places you may wait much longer to get formal reports. And I say we have such pressure on us to hit 2 weeks. Given most patients don't get referred till it's sort of 7 days, then a hot clinic, and then finding a list inside 2 weeks is very, very hard. So that's why there's the pressure from us to get a scan the same day.
Okay.
Just we're really struggling to hit our 14 days otherwise.
Okay, brilliant. Cameron, do you have anything to add? I mean, if I missed something or?
No, I thought that was pretty encouraging. I'd
Yeah.
be happy to go ahead with something that basically what's been proposed or something similar.
Thank you. I will keep quiet now. Let me just unshare.
I think we have a question from Dr. Sen.
Plenty, actually, I'm afraid. Hi, Nick. Morning.
Hello. Fire away.
Hi. I'm glad to see your presentation because that clears up a lot of issues really, you know, around this occlusion and greater than 90% and what the guidance is, which we were really struggling to understand so far, because when we were emailing that there seemed to be a variation in practice in terms of who we are getting or not. So I think if we have a criteria like what you have said, and maybe it needs a little bit of tweaking with Rekha's and our neuroradiologist input, but if we agree on a criteria, what I was getting at is, do we have to email you to get an answer saying we need a second modality, or if we and our, you know, if you and our neuroradiologist agree on a defined criteria for say under 60% and greater than 90% difficult body habitus, calcification, etc., we directly go for it and inform you at the end. It will save time. And the in between, the 60 to 90, as you say, we will contact and we can have a discussion whether you want a second one or not.
Exactly. I think that's very, yeah, exactly. So for those set criteria, they must have a second form of imaging, MR, CT, whatever it may be. Yes. Anything in between, refer it with one form, duplex, and then we'll let you know if and when we feel it needs something else, or we'll organise a second form here in a hot clinic.
Fine. So Rekha, maybe and Nick, maybe we can get together in another meeting to absolutely rubber stamp that criteria, and there is agreement from all sides, and it's not to and fro between us and you, or to and fro between us and neuroradiology here when these requests come through. Sure.
Yeah, sure. That would be great. Thank you.
Okay, we've already discussed the choice between CTA, MRA, and you know, that's great that we have some agreement at least for our Salford site. Rekha, just one point there in terms of MRA reporting is that what I was looking at is to start with, actually, some of these patients will be outpatients because they would be coming from our TIA clinic rather than inpatients. So we need to keep that in mind. So we need to have something written in the request or some form of flagging up saying, you know, these MRAs are for urgent CEA kind of second modality, even if they're outpatients, for kind of flagging up for reporting within 24 hours. As well as I think if we surely know from Nick, as we know that they are going to be hot clinic, what I was really trying to get is I don't ask for a CTA at midnight on a Monday. If that is, I know is a hot clinic, then I'm going to discharge that patient, bring them down for an outpatient MRA. And that, again, me and you and Cameron need to sit down and maybe arrange something. And I'm really keen that that happens during hours, reported by a radiologist during hours. We're not kind of swamping the on-call who is reporting thrombectomies and traumas. That's my whole interest about it. So
I think if we can have an idea of the numbers, then what we can do is we can try and see, like we have the 2 virtual ward slots.
Exactly. That's what I was getting
We can try and see if we have a set slot, and, you know, go that way, because you know, those
until
are prioritized, those are reported.
Until then, I think we'll try, if somebody's inpatient, we may just try to get it done, not asking you to do it in the evening, but get it done next day or something, and then let the patient go. But once we have agreed the criteria and everything, then we might look at that, Rekha, kind of discharge patients or TI patients, get a few slots. And I've asked Dominic already to start looking at how many abnormal Dopplers we have got and how many second modality requests we have got in the last 3 months to get an idea. But we can get a virtual MRA slot and go through that.
Yeah.
Okay. Nick, the other question we had is we, it is a new system and not everything's working absolutely perfectly as we would like to from both sides. There seems to be a delay in coming back just to say that we need a second modality, which is CT. I've recently met somebody on a Sunday who was sat there for about 5 days before an answer came to get a CTA. And when we got the CTA, next day, the answer came hot clinic. So that patient basically sat in our ward for 6 days. It's probably 1 or 2 at the moment, but it's certainly happening. So I was wondering whether when we first, one thing is trying to just get a second modality if there's an agreed criteria. The other ones, the 60 to 90%, if you come back to us saying we need a second modality, could you indicate at that time that if that second modality is confirmatory of what we see in a Doppler, that you would be seeing them in a hot clinic rather than or an inpatient transfer? And that, again, that allows us to kind of let the patient go do it in hours rather than running at midnight trying to do something.
Sure. I mean, I think at the moment our only clinic at Salford is on a Wednesday, so the chance of them being seen as an inpatient is less likely. Naz Ahmed, who covers that clinic, is doing feet and diabetic feet, so he's very swamped. So I think realistically, yes, the vast majority of patients referred will be seen in a hot clinic here. Just to clarify, they're fit or not. So you can almost assume that's a given, unless they're absolute wrecks on paper. But the most will be seen. So I think, if there's any doubt, a safe form of imaging and a hot clinic is the way forward.
Okay, that's great, because that's the impression I get, that most of them would be hot clinic. And I guess the only ones that, in my experience, that would get transferred inpatient would be kind of crescendos and recurrent events despite best medicals. That may be a consultant to consultant discussion then, but otherwise we will take it as a given when we are referring that this will be a hot clinic. So we can go forward and discuss with our radiology in terms of managing them with a scan maybe in 24 to 48 hours from discharge or 24 to 48 hours from Doppler, rather than running at midnight and swamping the on-call radiologist to report it. Is that okay? Brilliant.
As long as there is time pressure to get inside 40 days, however you do it, that's fine.
And your timescale for CEA is still 14 days. That hasn't changed. So we'll kind of, from Salford side, between us and neuroradiology, we will aim for that to kind of get whatever modality we need, first or second or whatever, within maybe a kind of 4 or 5 day time period to allow you to say within that. Is that something kind of feasible, Rekha, you think, in terms of, I mean, we'll obviously discuss the timescales and everything later.
We need to know the numbers, isn't it?
Yes, absolutely. But I'm saying as a principle to go forward, to
no, absolutely.
go on
I think
that route.
We'd rather want them having surgery before they have another stroke, rather than sitting on it. So absolutely. But I think, again, depending on the numbers and how we can try and sort it out.
Yeah. And the only other thing, Nick, is the thing I mentioned is about coming back in terms of an answer or outcome. We obviously like the faceless referral because we have spent hours trying to get to vascular SPRs, and sometimes they're in theater, so call back in the evening, it just goes on. So it's obviously great that we can refer via an email and then things come back by an email, because we want to do that as well via patient pass ourselves. But if we are a high pressure center, if somebody sits here for 3-4 days just to get an outcome of CTA or MRA, that does not really work well. And when we have called, because it's gone past 2-3 days, there has been some pushback from the other side. Now, I understand it's a new system, so I'm just saying, if if it is past 24 hours, there needs to be some route of letting you know that we are waiting for an outcome.
I think your comments are very valid. It is a new system. Most of my colleagues are very much on board with it. Some aren't as much, and it's a spectrum. So I'll have a chat with them and reinforce that we need to give answers the same day. And I think for now, if you have my contact details, so that if people have waited more than 24, 48 hours, you contact me and I will chase it and I'll try and sort it. And in the interim, we'll try and just to get it as a culture that it's as quick a reply as possible, same day.
Yeah, I was wondering, rather than a 1-point contact and trying to swamp you with this, would it be reasonable if this goes past 24 hours or 48 hours and we were worried in terms of our bed pressure or the patient, it becomes a consultant to consultant call from our stroke consultant to your vascular consultant?
Yeah,
so that
I
there's
think
no.
that's sensible. I think the only issue is that in knowing which consultant to speak to. So we'd have to give you our rota or get you a copy of our rota so you know who is on that week triaging things to contact them directly. Because the consultant on call,
Switchboard wouldn't know they. I mean,
they know who the consultant on call is. That person's not covering this job. It's the surgeon in on call rather than the consultant on the ward.
Yeah.
We can sort that. But you're right. That's a better idea.
Yeah, I think so. And then I think we need to talk a little bit about the email, because the email bit came a bit, too quickly for us. We haven't sorted out a generic email on our side. We were, Dominic is on the call. I think we were looking at an EPR request from our side, which will map what is on your request form. Exactly what is in your request form. So those information to put in our EPR, and then once we click it, it goes to your generic email. So we were looking at something like that rather than, emailing.
So I think at the time we're talking about patient pass coming on from our side as well. So this may evolve.
Yes, that's good. That was my last point, because we are going to use patient pass, and we feel that would be much more beneficial for us. We have a problem in terms of monitoring the email as to who mans it and etc. So patient pass will be much helpful for us.
This is a sort of a halfway house that's more efficient than the old system, but if we get bigger, we need something we can upsize, which is patient pass. So that is coming, just not yet.
Excellent. Thank you so much, Nick.
All right.
Perfect. I think we've got a question from Dr. Shivakumar as well. He's been waiting a while.
That's okay. It's exciting. Hi, Nick. It's Krishnamurthy here. Pleased to meet you. I think this correspondence has been through other modalities. The first time I'm meeting you, but I think Sri has been updating me on some of the background discussions in this regard. I think some of the discussions has already happened. My only request is listening to the conversation. It's very important. This is a GM pathway. So any standardization has to be sensitive to all the centers in terms of how it is, allowing some discussion within the statements, within the pathway, to allow for individual centers to meet their needs. So it's important. It is not tweaked to a center, but allows sufficient languaging within the criteria to allow for that center to implement that based on their pressure. So that's the first point. The second one was, it'll be good, I know you stated it, going back to Dr. Sen's comment, we are talking about a 14-day standard with multiple organizations involved, multiple stakeholders in terms of radiology, stroke service, and a highly pressurized environment. So the request for a standard, agreed standard of 24-hour response is not a big ask on that referral, particularly when the center is reliant on the feedback as to the next steps, and also the fact that the patient will not proceed to endarterectomy without a hot clinic. So I think it's not a big ask, and I think that should be in there as a commitment, a 24-hour response. I think it's for the organization to align themselves in terms of generic email, which we will take on board, and we will manage that, and they need to be manned 24/7. So I think that's for individual centers. In terms of my main, and I also get the sense, which I would like to clarify, that because it is seen in the hot clinic before surgery is proceeding, the likelihood is more or less like an urgent outpatient service. So the emphasis is, if the modality of investigation is undertaken, the patient could go home, provided we are comfortable in terms of other elements of that patient pathway, and the expectation will be the contact from the center, from your center to the patient. I don't see any, because we are doing the same. If the patient is sat for 5 days, then to a hot clinic, and then there, or it'll be the same process with it sat elsewhere at home. So I'm not too much hooked on to that. What might be useful is, again, going back to Dr. Sainz, is there a sub-criteria where the likelihood of in-hospital transfer is highly likely? It'll be good to make a reference to those patients, whether it's a crescent ATI evolving. so that at least there is some, because we are relying on a lot of individuals to make this happen. And it's best to have criteria and some reference. So if there are these like patients are likely to be, it doesn't commit to anybody to anything, may result in an inter-hospital transfer, which will help us to home in on whom we can send home and who will not, with the modality undertaken, I suppose. The last point is about outpatient service. That is slightly different because for us personally in Stepping Hill, it's if you have a patient, if they need another modality, we get it done. Reporting is an issue for us, but I'm pleased to hear that it is not essential. We will report it in due course with a 24 or 48-hour standard. We do have a standard, but particularly for CTA, but we can't report it the same day or there'll be a delay in it. So I think it doesn't bother us much into the inpatient. The outpatient is slightly different because it goes into a generic pool. So there is going to be challenges about CTA for an outpatient patients in the TIA clinic. I think we will need to look at that and problem solve. If there is any leeway on that, we will be helpful to know. I think in those patients, we would definitely initiate a referral, request the CTA, and then wait for things to happen. I think we don't have a standard now for the outpatients. We relied on the transfer to the unit or to be seen in the hot clinic and for you to organize it so far anyway until this time for the outpatient. Inpatient, we did it, always did it. So I think there is a significant service change for us with that expectation, which will be a challenge for us. Just to be aware, I'm not saying the solution looking towards you to do that, but nevertheless, it needs to be acknowledged.
Sure.
So that's all I have to say. Thank you.
Thank you. No, I take on board all your points, and I think every site's going to have slightly different pressures. And as you say, whether it's CT for you and MR at Salford or however it works, we're going to have to adapt it and leave the wording slightly vague so you can take it to your needs.
Thank you.
Thank you. And we've got Dr. Vassini who wants to pose a question.
Thank you. Hi, Nick. Javier Vicini, stroke consultant from Salford. Yeah, just very briefly, I did an audit of the carotid stroke, the carotid CA pathway back in 2018, and we assessed all patients from that year. We correlated imaging modalities. And actually, what showed were a couple of things. One, the correlation between modalities was much better between ultrasound and MRA, mostly contrast enhanced MRA. Actually, when we did CTA in about 6% of the patients, those had a clinically significant difference that had to be confirmed by a different and again a modality which ended up being MRA most of the time, or a second ultrasound, which of course is why I completely get Rika's point as neuroradiologist about choosing routinely CTA as a second modality. That the results from that audit were quite clear in that regard. There were no discrepancies between ultrasound and MRA at all, and that was a very large patient population. And the study, the audit, not to blow my own trumpet, was very, very detailed and exhaustive. The other bit that the audit disclosed was that we didn't get feedback, so we didn't know what happened with the patients once they left our walls, so we of course we didn't have a chance to assess the quality. Of course, not to mean that we doubt the quality at all, but you might understand that as a stroke center, we would like to know what was the rate of complications of the patients we referred for CEA. So it seems like most of those issues will be sorted out via having a common generic email in our trust to where you can refer the discharge summary from the patients that we have referred. I think that's one. And the other question already Doi had dealt with it, which was essentially, yeah, I mean, the patients kept waiting there. And this is, I know, a bit of an acid question. and sorry, don't mean to get you in cold blood. It's just, is it right for us to assume that once we have referred the patient via patient pass, you will take over the baton and the patient won't need to remain in hospital unless necessary?
I think that's a reasonable expectation. I can't speak for every circumstance, but I think in principle, you know, we should be responding within 24 hours, and we should be able to tell you from that whether we think it's complicated or not, and therefore whether they can be discharged with the appropriate imaging as an outpatient or in the near future. That sounds very sensible and probably the best way to do it. So yeah, hopefully.
Okay, that was me. Thank you.
Thank you.
Okay, Dr. Shirapurapu, Rekha, would you like to ask another question, or?
I'll wait because I think someone else had raised their hand before me, probably Saravanan. So I'll let him go first. I won't jump the queue.
No, that's fine. Rekha, you can go ahead. There is nothing. I'm just going to ask about, you're okay, I think, with regards to vascular surgeons, you're happy with dual antiplatelets or something that, because this is something, some of these patients, when we see in the TIA clinic with this one, they might need dual antiplatelets, and you're happy.
Fine. Absolutely fine. Yeah, we're low maintenance, so dual antiplatelets is absolutely fine. We'll operate on that. It's not a problem.
Okay, that's fine.
Thank you. Nick, completely outside the protocol. Do you know when we have patients with less than 50% stenosis, but if I do see intraplaque hemorrhage and an ulcerated plaque and a complex plaque, I report it. Sometimes I say, please speak to vascular surgery. Is that causing you guys too much trouble? I mean, do you just not want to know about them?
We've had a few of these, and it's really a 50-50 split amongst the vascular surgeons here, where it's less than 50% on CT, but you can see it's a big, ugly, ulcerated looking plaque. And I'm personally very aggressive and would go on and do it.
Okay.
I think all you can do is flag it up. That patient's brought to our MDT, and we sit down and have an MDT discussion and make a decision. But yeah, there's a growing evidence from a lot of our carotid research here that these ugly, nasty plaques are the high-risk ones that need doing, even if it's less than 50%. So I think absolutely you should flag it up and bring it over.
Brilliant. Thank you.
Thank you, Rekha. Nick, I completely agree, Nick. I think we have actually done one or two in the last 2-3 years, which was, I clearly remember 145% and a floating thrombus. So those kind of things, Rekha, would be really grateful if you flag it up, because I think the one other thing that kind of directs us towards speaking to vascular in these scenarios and going for CA or not is the clinical scenario as to whether these are kind of recurring crescendo events or whether there's a single event and the patient has been stable on some anticoagulation, antiplatelets. I think that really needs an MDT discussion, but I think we'd certainly want that to be flagged up so we can have a discussion with you and Nick on both sides and decide on radiology and clinical. And we've certainly done one or two in the last 3 years.
Yeah, I agree with that. Good. Anybody else?
I think that's all for the questions today then,
Okay.
Dr. Greaves.
So can I just
sorry.
my questions to you guys? Are you happy to run with this in the going from now? We can carry on with this pathway because we're auditing it as we go along. If there's any feedback, email me and I'll try and add it in and tweak things. As we said, patient pass is coming in the future from our perspective, but not yet. I will certainly get back to my colleagues about responding within 24 hours. And if you in time can provide us with generic email inboxes for discharge summaries, we can pass that to our secretaries to pass on the discharge letters, because I know that was quite a big bugbear, particularly at Stepping Hill in the past, that they weren't finding out what happened to the patients they'd referred. But unless there's any other issues, I think we just carry on as we are for now, because it seems to be working okay.
Nick, for clarity, am I right in saying if there is any change to the criteria and or subsequent to further discussions will be made aware? Until then, we are going with the current thing, and this slide will be shared.
Yeah, the slides are shared, absolutely.
Okay.
No, thanks, Nick. That was really useful. Just a couple of things that we would want to discuss with you, but I think otherwise we're okay with most of it, and you're happy for MRA, so I think we can.
Yeah, so I mean, I think we're less familiar, and we'd have to have a trial 3-6 months of seeing how much the reports correlate with the plaques that we see intraoperatively. I'm sure we're going to be happy, but it's just that we are much more familiar with CT at the moment. It's just a matter of evolving our practice to catch up with MR being used more frequently.
No, I think we do CT as well. You know, if
Oh, I see.
you know,
Okay.
yeah, it's a combination, but
Sure.
probably MR will be more than CT. Only in
understand.
terms of this. Yeah. Okay.
I
And if it's more than 90%, we'll ask them to leave it to you guys if the Doppler is categorical. I mean, we'll discuss that later on.
Yeah, I mean, certainly a second Doppler as a minimum on the day of surgery is what we'd want,
Okay.
but ideally a second form in between. But we can discuss that later.
Okay. Cheers. Thank you.
Okay, perfect. Thank you so much, Dr. Greaves, for doing that, and thank you everybody else for the interaction and all the questions. I hope that was beneficial. If you could please for us just evaluate the actual webinar with 5 being excellent and just by leaving a number in the chat box, that would be great. 5 being excellent and 1 being poor, so 4 being good. And then I think 3 not either way, and then 2 being satisfactory. So if you just let us know, just it would be good to try and help us plan for further things like this. But that's great. Otherwise, thank you so much for attending. Brilliant.